Velkommen til en omgang Mød Selskabet. Denne gang med 2cureX, som er et biotekselskab, et medicinalselskab, der arbejder inden for kræftforskning, og det er den individualiserede behandlingsform, som vi skal tale lidt om. Et selskab, der har en historie, der går tilbage til nullerne, som har været her i en del år og har haft en del udvikling, men som det seneste år er gået i en, kan man godt sige, et nyt gear, og det er noget af det, vi skal høre om i dag. Så med mig har jeg både her i studiet dig, Ole Tastrup, CSO, det er Scientific, det vil sige, men du er også den oprindelige direktør for selskabet, ikke?
Founder og direktør.
Ja, og så har jeg derudover med mig på en forbindelse Fernando André, som who is also with us. Welcome to you, Fernando. It's the CEO of the company. Men we'll just stay here in Copenhagen for the while. Og så lige inden vi starter, Ole. Vi stod her sidste år, du var med sidste år også på Investorugen, og det er jo godt at se jer igen. Der er sket en del herunder, at de har fået ny CEO. Kan du ikke lige sætte ord på året?
Jo, det har været et meget hektisk år. Det har været et super spændende år, og som du siger, så har vi været her i mange år. Så har vi faktisk startet i 2006. Og vi har udviklet vores teknologi, vi har beskyttet den, vi har lavet kliniske studier, fundet kliniske partnere i Danmark og i udlandet. Og i slutningen af sidste år, der kunne vi se, at nu er den der. Det her, det virker virkelig. Vi var lige ved at afslutte et klinisk studie, som har været en stor succes. Ja. Og så skulle vi simpelthen have flyttet selskabet fra at være et R&D-selskab til at blive et selskab med produkter i markedet. Og her skulle vi finde nogle kompetencer, der havde gjort det før. Og der er jeg utrolig glad for, at det lykkedes at overtale Fernando til at joine os. Og vi har også ændret ledelsen på andre niveauer. En ny CFO, en ny VP for Business Development, en VP for Sales. Og I vil se i den kommende periode, at vi udvider især på den del, så vi bliver sådan et full-fledged product company.
Sådan en kommercialisering.
Yes.
Men altså, det er jo også derfor, vi er glade for at have jer her, men også at have Fernando med, så altså new CEO. Til jer derude, så går vi over på engelsk om lidt til præsentationen. Ole er med her i studiet. Vi tager bagefter spørgsmål og svar på dansk. Går tilbage til Fernando også, så det bliver lidt frem og tilbage. But Fernando, André, welcome to you also. Can you hear me here? Okay, thank you.
Yes,
we're very happy to have you with us here, and Ole just mentioned that he is also very happy to have you in as a new CEO of the company, and we have agreed that the three of us that you will take us through a presentation of the company, 15 minutes around, and then we'll take some Q&A. Some of them here in the studio, but if something comes up, also with you, Fernando. So I'll pass the word to you, and you can give us an update on the company.
Sure, I will, and hopefully sharing my slides, my screen, and I hope you can see it now.
Yes, yeah, that's fine.
Okay, so well, there is obviously a disclaimer page. I think you're all familiar with forward-looking disclaimers, and then I would like to start with an opening statement saying that drug sensitivity testing is on its way to transform oncology practice in exactly the same way that genomics testing did 20 years ago already. And this is a strong statement because genomics has really changed everything in oncology practice. But I hope by the end of this presentation today you will understand why we are saying this, and you will agree to that. So starting point is what is it that we are trying to address? What is it that we are trying to fix at 2cureX? And what we are trying to fix is a critical issue, which is the heavy unbalance between the amount of money that is spent every year in oncology and the outcome of this, the result of this investment. And just if you look at the left side of this slide, you will see here, for example, already 12 years ago, WHO published a report where they were estimating the total burden of oncology. Total burden meaning direct and indirect costs. And they estimated that back in 2010 in 1.16 trillion US. More tangible numbers, more research expenditure. That's direct expenditure in drugs, in oncology-related drugs, $206 billion US. In oncology-related diagnostics, oncology-related tests, $18 billion US. And within these $18 billion US, $3 billion specifically related to assigning drugs to specific patients, what is called companion diagnostics. Okay? Now, this burden is increasing heavily because what payers, what societies and health administrations are facing is increasing number of patients, increasing number of drugs, and more expensive drugs. Now, when we look at the other side of vision, what is the outcome of this? Unfortunately, it is very, very limited. So first, patients are not cured by drugs. They are mainly cured by surgery, and then drugs are an adjuvant therapy, or in many cases, a way to extend the patient life, but not to cure it. That's the first thing. The second thing is a lot of these drugs, most of these drugs are actually used not taking into account individual response patterns, but they are given on a general level. Actually, if you look at this slide, 73% of guided by any individual biomarker predicts whether this patient will respond or not to the drug. And out of the 27% where a biomarker is used to guide the therapy, actually only 1/3 of those respond to the prescribed drug and 2/3 do not respond. And that's what we call precision oncology. So there is an obvious need to change that. There is an obvious need to bring, and this is our vision, to bring precision oncology to all cancer patients. So how does it work with IndiTreat, with our test? Out of 6.8 million new cases per year of patients who will go on drug treatments, out of these 6 million, considering the percentages that we saw before, 5 million are going to have a therapy which is not guided by any biomarker. And what we have here, and it's hard to say, but it's trial and error approach. So the oncologist is going to choose a treatment, is going to try this treatment. After a few months, we'll see whether the treatment works or not on that specific patient. And then if the treatment is not, the patient is going to be switched to another treatment. So literally trial and error. Here, our test IndiTreat can provide guidance where these conventional biomarkers are not available, because our test, our functional test, predicts resistance or response to treatment. So that would be a very valuable tool for the oncologist. If we look at the left side of the picture, we have this 1.8 million, where a biomarker is guiding the therapy. But actually, out of this, as we saw, 1.1 million will not see anything. Now, here, the combination of molecular biomarkers existing today with the IndiTreat information can dramatically increase the predictive value of this. So, at the end, our vision goal is that every treatment decision should be supported by a test that is predicting whether this treatment is going to work or not. And that would dramatically increase the picture that I was showing in the previous slide. In the next slides, my colleague Ole Thastrup is going to share with you some details about the technology behind the test, and then I will take over again.
Thank you, Fernando. And if we jump to the next slide, there it is. What I will just shortly present to you is the IndiTreat process. What you see here is the product that we are putting into the market now, that is for colorectal cancer, metastatic colorectal cancer. The process is that the first image shows a patient, a CT scan of a patient's liver. The dark areas, that is metastasis, that's the tumor that have spread to the liver. We take a small sample of that, and then we make hundreds to thousands copies, small copies of these, we call them microtumors now, that resembles the tumor in the patient. We have loads of data that we have created together with clinical partners at Skyby, at Bispebjerg, Rigshospitalet, University Clinic, Eppendorf, Hamburg, where we have shown that our microtumors resembles both genetically and functionally the tumor in the patient. What we then do is that we challenge these small guys with drugs that are approved. Very importantly, we are not making new drugs. We are taking the drugs that already are approved in the marketplace. The ones you see there in the right-hand corner, that's the drugs that are being used within colorectal cancer. In the middle panel, you will see how in the top that the tumor will just grow if we are not doing anything to it. And the lower panel, we actually show that we have found a treatment that works. The growth have been inhibited, and then we deliver a report to the oncologist. Let me just take you through a couple of these. I mean, so we measure growth. Does that make sense? Yes, it does, because that's exactly how cancer development is measured in the clinic. There they do often a CT scan, and you will see here an example of a treatment that actually does work. So they measure the tumor being 53 millimeters, and then it actually shrinks to 23. This is exactly the same we do in IndiTreat. We use the growth parameter to see whether we can inhibit that and thereby inhibit the development of the cancer. As I mentioned to you before, we take drugs that are already in the market. There are fantastic drugs on the market. The biggest problem is, however, is to match the individual patient with an effective treatment. That is exactly what we do, and all the types that are approved, we have that in our panel. What you see here is that it's a very complicated analysis to see whether these small tumoroids grow, and also if they are small tumoroids, small microtumors. And here we have artificial intelligence and machine learning that we have developed that can go in and find each of these small guys and quantify them. That quantification will then go into a complex panel. I won't go into detail here, just say the very important thing that the oncologist is not only getting how does this patient respond to one of these treatments. The oncologist will also know how will a panel of reference patients. If I take a panel, it could be of his own patients, it could be a patient with a specific mutation. How does this panel, this patient respond? And from there, he or she will take a treatment decision. Now, very importantly at the end, we have shown that the system works in a clinical trial that we conducted over the last 3.5 years. We finalized it here in the beginning of 2021, and we actually presented the data at the American Society for Clinical Oncology ASCO meeting in June. And very short, this trial showed that we could increase the number of patients that had stabilized their disease with 150%. This is an extraordinary achievement. And what not only does it say we can help this group of patients with metastatic colorectal cancer, it also opens for a number of other IndiTreat products to be launched in the years to come. And with that, I will actually give the word back to Fernando.
Hopefully,
seems like he is not with us at the moment, but if he comes, then we will put him in. And it's a good thing that I have the OCO here, because he is a little bit into the business, so he can maybe talk us through some of these, or if not, I have the questions ready.
I could also maybe start here. And
exactly.
Fernando could chip in.
Yeah.
So then let me take this slide. What you see here is the treatment circle of colorectal cancer patients. What we want to show is that the IndiTreat technology can be used at different time points of the patient journey. So it could be that the patient come in and will receive surgery and actually is cured. If that's the case, IndiTreat will not be used. But unfortunately, that's not the case for most of the patients. They will need treatment, and you will see here, at 3 different spots in that process. And in all these, IndiTreat can come in and help.
Okay, and we should be connected again to Fernando, my colleague says. Fernando, are you with us? Can you hear me, Fernando? Seems like there's still something. You just continue and we can hear Fernando at 1 second. Yeah,
okay,
just take it away.
Yeah, let me then say that we are rolling out our first product, and actually Fernando is on the road.
That's why he's not here.
That's why he's not here, and that is to talk to a number of distributors that we have made agreements with that are going to talk to the hospitals and get the products into the hospitals. You will see new products coming from us, and actually already this year, well, we don't have more than a month to go, but we have a new product that is in first-line metastatic colorectal cancer. We expect to launch this year.
Okay.
Let me then jump to the next slide, and this is why is it important to have the first IndiTreat, what we call MCRC, third-line product. So these are patients in their very late stage of the disease. What you see is that 160 days or 152 days, that's the normal number of days where they survive the disease. So the overall survival, as we call it. We have 2 treatments that we can select from, and that is the top one that is two drugs, a combination. The combination called TAS-102, and you will see we increased it from 160 to between 195 and 235. If it's only 195, then a number of clinicians will say, oh, that's not enough, because there will be side effects. But we will be able to find the patients that actually go up in the high end, and that's the same with the other treatment. That shows the benefit of this drug, this treatment. And let me just show you of the products to come here in a month's time. There we have 2 treatments, combination treatments we can use, FOLFOX, FOLFIRI, and you can actually use the one or the other. But what's shown here is that it is extremely important that you pick the right one at the beginning. And because in the top you will see that the red bars, the red triangles just show that you pick the wrong of the 2 to start with, and then you treat it with the other one later. So if you make the wrong decision in the beginning, then you will only have 24 months, 2 years here, overall survival, and it's actually doubled. You will see that's the same with the other. And that's very important for cancer, is that you cannot, even though you say, well, we will treat with the other one later, but the effect of a subsequent treatment is much, much worse. This is the product you will see coming in about a month's time.
Yeah.
So then some have asked us, why have you taken colorectal cancer? I mean, there is a lot of solid cancers. We have taken this because, we have Fernando back.
Yeah, Fernando, can you hear us? I think we will just ask Ole to finish the presentation, and then we can take some questions. I think that will be better for the viewers, just to continue on the presentation, and we'll have a question afterwards.
Right. So then I will.
Yeah, that's right. Is
so
it here?
This is really what Fernando and his team is working hard on this moment.
Yeah. So we can also ask Fernando, but I would like to, because we have of course your presentation, but there's so many good questions around, like how far are you now on actually going to the markets with in Danish tyktarmskræft is the area that you're working with. So so if that's the case, then feel free to ask Fernando to tell us how far are you with like rolling out the products, if you can hear us, Fernando.
I don't know if you can hear you.
Great.
Welcome back.
So how far are you now with your rollout and going to the market?
Yes. So what we have done in the last months is we have developed. we are building and developing the country. Because what is really important is it's one section of the oncology, and I think that the interest of oncology in what we are offering in our test and in drug sensitivity testing in general. But then they have to be able to buy our test. They have to be able to use our test in routine practice. And for this, of course, are complications that have to be undertaken hospital by hospital, and sometimes in some countries there are centralized reimbursement schemes, etc. So for all of this, we need to have local infrastructure. And what we have been doing in the last months is building this local infrastructure. We have signed up new distributors in many countries, and this is now our priority in the coming months is to continue to build up this network of distributors so that we have the right infrastructure in place in order for oncologists to be able to access our test.
Interesting. Ole, back to you here in Copenhagen. If we take the case maybe in Danish afterwards, maybe there was a few more slides that you wanted to show us, because the internet connection to Fernando is not the best, so therefore I think it's better to connect with Fernando for specific questions. But how is life? Is there any other any slides you want to show, or should I go to the Q&A with you?
I mean, I think you can go to the Q&A. I think the most important thing is that we are now in the rollout phase, and we have specific products that can help in daily practice. So I think we should use the time for it.
And also, I mean, I don't care with internet connection problems like this if Fernando actually is out on the road for selling, and he is. so therefore, the shareholders want to see some results, of course. We just turn into Danish for a few questions here. Men det lyder som om, at I er et sted, hvor, om man så må sige, så kan man sige make it or break it, men altså I er et sted med jeres produkter nu, hvor det er de næste 6 måneder, 12 måneder, 18 måneder, som kommer til at betyde meget.
Det er fuldstændig rigtigt. Og det, jeg vil anbefale, at investorer og aktionærer skulle se efter, det er vores evne til at etablere aftaler i de forskellige attraktive europæiske markeder, og vores evne til at få disse distributører til at line hospitaler op. Som Fernando lige nævnte, der kommer en proces nu, hvor hospitalerne får lov at prøve. De skal se, det virker i deres eget hospital, og så bliver de langsomt guidet ind til at blive fuldt betalende kunder. Det, der virkelig er afgørende nu, det er at se penetration. Se den begejstring, vi har, den skal vi se på hospitalerne. Og allerede det er vores team, som i øjeblikket befinder sig i Spanien og Portugal, har set, det er, at der er en meget stor begejstring. Så nu skal vi have den skal vi have kanaliseret ud.
Ja, det er klart. For dig er det også kunne jeg forestille mig, det må være en stor glæde, når man har arbejdet med et projekt og en virksomhed i så mange år, at se den komme det her skridt videre. Så det er jo selvfølgelig på aktionærens vegne og krydse fingre. Hvis vi ser på det tyktarmskræft nu, og i virkeligheden, altså det er ligesom det område, jeg arbejder med. Og jeg tænker, det er nok også det, I arbejder med et år eller to, fordi det gælder om at komme ind der.
Ja.
Og så er det muligt at tage nye kræftformer med, eller...
Ja, altså. og jeg vil sige, at vi har startet projekter i 2 andre kræftformer, i kræft i bugspytkirtlen, som er en forfærdelig kræftform, og kræft i æggestokkene kvinder. Men som du siger, altså tyktarmskræft er så kæmpe et område, og vi vidste jo ikke, at det blev så succesfuldt. Det ved man aldrig med et klinisk studie. Så nu fokuserer vi virkelig på at få tyktarmskræft ind, og så udvikler vi det andet i baggrunden. Så I vil se i løbet af det næste år, der vil komme flere. Men nu skal vi se, at det virkelig bliver taget op.
Hvordan er et selskab som jeres fundet til? Altså, jeg har skrevet hernede her, er der penge i kassen? Altså, hvad har I penge til at tage de her 2-3 år? Jeg tænker, eller mere. Jeg ved, altså, prøv at fortælle lidt om jeres fundingssituationer og fremtidige budgetter på den måde.
Jamen altså, vi har penge i kassen, og med de planer, vi har lagt for en europæisk rollout, så er der midler til at få den kørt hjem.
Okay.
Så lige nu, så ser det sådan set finansielt fornuftigt ud.
Okay. Maybe I should try, Fernando, if you can still hear us, to ask you as the new CEO, what's the main targets for you in 2022? If you should put out some like targets.
Well, actually, we have announced recently that we want to be present in 20 countries in Europe in 2024. We want to have at least 30 hospitals who are using our IndiTreat test. That would be the ultimate sign of and that the test has become part of the routine clinical practice in oncology. So that's our main goal, and obviously together with this, generating for the first time.
And that's a European task, I guess, for you and your colleagues to travel around Europe. When is it going to be commercialized then? I mean, as I hear it first, we have tests, then there's a commercial phase afterwards.
Yes, so we expect that the transition between so for us this is already commercial. This is commercial phase, so to say. So this introductory program that we have now is not really to evaluate the technology or the products. It's already evaluated and agreed. This is more a soft to enter the routine and the process in the hospital, the clinical process in the hospital. So we think it's a matter of a few number of patients between the hospitals trying the test and then integrates it into the routine clinical practice.
Great. I'm sure that hopefully we of course apologize in Danish that for the internet connection, but it's I think it's still important, Fernando, to have you here because Ole was also here last year, and it's very important that we actually hear about this commercialization phase. But I will end up here in the studio with you, Ole, and in Danish again. Det vil sige, der kommer et år nu, hvor det handler om at komme ud. Både, jeg hører jer sige, I skal have et nyt produkt med ud. Kommer det? Er det 2 produkter, der skal ud til de samme hospitaler? Ja. Og så er det ellers ud og banke på døre og få lægerne overbevist om, at de skal bruge det.
Ja, og det er jo distributørerne, som har netværket. Ja. De vil så trække på os. Altså fordi de siger så, nu vil vi godt lige have, at der kommer en fra 2cureX og præsenterer det her. Men vi må indrømme, at den træning, vi gennemfører lige i øjeblikket af distributørerne, altså de er imponerende gode til at samle selve forståelsen af teknologien og hvad den kan gøre for patienterne. Så jeg tror rigtig meget, hvad de kunne gøre. Ja. Men selvfølgelig, vi står der og backer op med materiale og også tager derud.
Og Fernandos baggrund, hvad er den til? Altså, hvor kommer han fra, bare lige for at få det sat på plads også?
Fernando har gjort det her adskillige gange. Og det er fra store selskaber, Roche Diagnostics, Sysmex, og det er fra små innovative selskaber i Europa, i USA. Altså han har været på den her rejse. Han har en kommerciel baggrund. Men vil jeg sige, now you can't yet understand my Danish, I'm afraid. We will have to work on that, Fernando. But so I can say here, at han har en fantastisk evne til at samle op, hvad der er vigtigt i teknologien. Hvordan får vi den præsenteret til dem, der skal betale for den. Og det er det, vi høster ind.
But to both of you actually, and to the viewers, to jer seere, som har set med, I would like to thank you for coming and attending here also. And Fernando, next year in this Investor Week, hopefully we'll see you again. Maybe next year we will see you here with the desk, or if you're out there selling. But we will of course follow 2cureX and be interested to hear from you. Hopefully even before next year in November. So feel free to come around to the studio next time you're here in Copenhagen. And Thank you, Ole.
Thank you so
and
much.
Also thank you, Fernando. And good luck to you both.
Thank you.
Og til jer derude, tak fordi at I så med, og jeg håber, I blev klogere på 2cureX.